Well, welcome everyone to our June edition, our first June edition of High Rounds. I think a little bit of a change, which is nice, a little international grab by our wonderful Kathy Promer, who is an infectious diseases physician at UC San Diego Health and San Ysidro Health. She did her residency and fellowship at UCSD. She studied Chagas during her fellowship, and she strives to promote awareness in her current practice in HIV primary care, general infectious diseases, and I'll also note adult or elderly HIV care, which has become a new expertise for Kathy as well. Kathy, I'll turn it over to you. I will keep an eye on the chat and let you know if there's an interruption. But try to see it. I'll give you a warning at the end and save some time at the end.
Okay. No, I have no financial disclosures relevant to this presentation. I'll be talking about the epidemiology, manifestations, and management of Chagas disease, and then wrapping up with screening, which was, I think, the main message I wanted to have with this presentation. Okay, so for epidemiology, sorry, I'm just gonna. Chagas disease is endemic in 21 countries. In fact, it's estimated to affect 6 million people worldwide. And about 70 million people are at risk of becoming infected. And there's an estimated 30,000 cases annually, new cases, causing an estimated 12,000 annual deaths. So, although it's just endemic in countries in Latin America, it affects residents of many residents outside of Latin America, including the United States, Canada, as you can see a lot in Europe, because of migration practices and the chronicity of disease. Specifically in the United States, it's estimated that 300,000 residents are currently infected, most of which aren't aware of their infection. And about over 10 years ago, there was a study on the potential impact of Chagas disease. And so these numbers probably have increased since then. It's estimated to lead to 118 million healthcare costs and 28,000 disability adjusted life years. And so there's been various studies about prevalence of Chagas disease in the United States, kind of focusing on areas with a high amount of Latin American immigrants, including Washington, D.C., a lot in Los Angeles, where there's a Center for Chagas Excellence, Boston, and here. As you can see, if you're kind of picking and choosing patients that with a high pretest probability, the prevalence can be quite high. But just even screening for all comers, the numbers are not insignificant. And one particular issue of consideration is watching out for congenital Chagas in the United States, excuse me. And a study showed that screening for congenital Chagas would be cost saving, even if our diagnosis rate is quite rare. And because of the cost of screening is so small, and it can be lumped into like a prenatal panel, and the potential implications for saving in morbidity and healthcare costs is quite high. There's been studies about prevalence in women of childbearing age, in Boston, 0.5%, and in Texas, 0.25%. But of note, these are Latina mothers, but they weren't necessarily born or lived in Latin America. So the numbers might be higher if you know that the woman was had lived in Latin America or rural Latin America. And overall, we don't have many documented cases of congenital Chagas, although from what we know of the epidemiology, our assumption is that we're just underdiagnosing it. And I'll talk more about the presentation of it. So why it might be, you'd need to have a high index of suspicion to identify it. And so in case you missed this recent California Health Alert Network email, Chagas disease is actually reportable now in San Diego County. It's been reportable in LA County for a few years, I believe since 2019. And it's reportable in a few other states, but I believe not in California state at this time. And so since it's only recently reportable, obviously they're still gathering data. The transmission occurs most often via the vector, the reduvid bug, kissing bug. And it can also occur congenitally, as I talked about, blood transfusion, organ donation, laboratory accidents, and foodborne. If you're ingesting something that has a lot of particularly the bug vector in it, like a juice or something like that in an endemic country, that might be a mode of transmission. But really the most common mode of transmission is vector-borne. I'll talk about that in a little bit. Oh, sorry. Okay. And so the infectious agent that causes Chagas disease is a protozoal parasite called Trypanosoma cruzi. Here's some picture. The one in the right upper corner is a picture of the trypomastogote in a blood smear. And the picture to the left of that is some amastogotes in heart muscle tissue. And so here's the summary of the life stages of the trypomastogote. And the way someone gets infected is that, the classic form of transmission, the vector-borne transmission, is the triatamine bug takes a blood meal. And then they defecate near where, they took the blood meal, and then the feces make it into the wound and carry the parasite. And so the mobile forms of the parasite, make it into the bloodstream and to organs, where they kind of establish into the amastogote form, promoting inflammation. And there's a thought that maybe there's a kind of a dormant form of the parasite, leading to helping to contribute to chronic infection and evasion of antiparasitic therapy. And so as you all probably learned at some point in your training, the classic story of someone getting one of these bites is sleeping at home, or sleeping in some sort of housing where bugs can get in, be it unmortared brick. This is a picture in southern Peru, or mud walls on the bottom, or a thatched roof, which I don't have a picture of. And so where does this occur? We think of, this is an infection in South America. And as you can see here, really the hot spot is, the northern portion of South America, northern Brazil, Peru, Bolivia, etc. But really, just, the next category down is right near us, as you can see, in Mexico. So, bright orange is the highest vector, or bright red is the highest vector transmission, and bright orange is next down. But fortunately, over, in recent history, the vector transmission is, it's assessed to be improving. And that's because of various measures, with housing and spraying, spraying pesticides. But as you can imagine, the triatomine bugs, don't get, stopped by Border Patrol. So, we actually have the triatomine bug vector in the United States. Although it's somewhat complicated because we have different species, even just within the United States, and there's, variations across Latin America. So, there's also speculation, there's speculation that maybe we don't see it happening locally as much because of different housing standards, or maybe the bug isn't, the bug vector isn't as likely to defecate around where they took a blood meal. But it, it certainly is possible. So now to move on to manifestations.
Kathy, there were just some questions about whether your slides were displaying. You're fine. Nothing for you to look at. All good.
If the
I didn't know if you saw the thing going off and everything's fine.
Oh, okay. Sorry. Let me know if there's a slide problem.
No, you're great.
Okay. And so, so with Chagas disease, the different phases are acute and chronic. So for acute, 1 to 2 weeks after, the classic vector-borne exposure, develop the acute phase of illness. And if that goes untreated, then you go into the chronic phase. By definition, if you have no symptoms, it's kind of like, I would liken it to like latent phase, like latent tuberculosis, where you have no symptoms, but you still have the infection. And then in 20 to 30% of these patients in the chronic indeterminate form of infection, they develop chronic phase with determinate forms of disease and end organ damage. So now to talk more detail about acute Chagas disease. It can be asymptomatic. You can have a chagoma at the portal of entry. The classic one that we learn about is Romagna sign. You can see a picture of this. That may be it's assumed that the bug vector, took its meal around the eye, leading to inflammation around the eye. Can have fever, lymphadenopathy, or in more severe forms, myocarditis or endocarditis. At this phase, or at this stage, the best way to diagnose it is via blood smear or PCR. So we're in the United States, we're very unlikely to see this form of the disease. With congenital Chagas disease, it can present with low birth weight, prematurity, low APGAR scores, hepatosplenomegaly, anemia, and thrombocytopenia, and then some more rare and severe forms of the disease. But as you can see, a lot of the more frequent findings there's a lot of other possible explanations. So you would need a high index of suspicion. A lot of the torch infections can present very similarly or non-infectious causes. And so Chagas cardiomyopathy is, the classic form of chronic determinate disease that we think of. Early on, you can have some more mild conduction defects. The classic ones are right bundle branch block, left anterior fascicular block. Later conduction defects are various Brady and tachyarrhythmias. And then as time goes on, patients can develop dilated cardiomyopathy with congestive heart failure. And this is an example of a apical aneurysm that can occur. Chagas can also affect, so with cardiac Chagas, it's working on the nervous system of the heart. Chagas can also act at the nervous system of the gastrointestinal tract as well, leading to megaesophagus and megacolon. So this can present with, swallowing difficulties, obviously bloating, constipation, and it's generally something that we see more. It's more rare than that we would see this especially in the United States, and more so in immigrants from South America, if we do see it. And then there's another scenario called reactivation, where a person with chronic infection becomes immunosuppressed. So, most commonly this would be in a patient that develops AIDS and organ transplant recipients. And one distinction between the two causes of immunosuppression is that in AIDS, you more often see CNS disease, whereas in organ transplant recipients, you would more often see skin lesions. So just to talk more about CNS infection in patients with AIDS, it can present with meningoencephalitis, but it also can present with rim-enhancing cerebral lesions similar to toxo. And it's actually in the DHS guidelines to consider it in the differential in the appropriate, or the patients with appropriate epidemiological risk factors. Diagnostic testing, beyond the serology, you would do a Buffy coat, of the CSF, looking for the actual trypomastigotes, the parasites. You can check for PCR of the CSF, which would be very hard, and I think you'd have to get that through the CDC, so not an easy thing it's not something you can just order in Epic. Brain biopsy may be needed to establish the diagnosis. Now to move on to management. So, you're seeing someone and they have a positive Chagas serology. This is kind of the scenario for that. What do you do from there? So you do a complete history, physical exam, EKG. Also if their social history isn't well documented, really going into, where they've lived, trying to see how higher index of suspicion is for a true exposure. And if everything is normal, just follow them annually. And this is just for clinical monitoring. I'll talk about antiparasitic treatment later. And if they have symptoms or signs consistent with Chagas cardiomyopathy, palpitations, fainting, symptoms of heart failure, et cetera, then do a complete cardiac evaluation. I would have a low threshold to go ahead and send them to the cardiologist as well, doing an echocardiogram, ambulatory EKG monitor, other tests as indicated. And if symptoms are consistent with gastrointestinal disease, doing the appropriate imaging with esophageal or colonic barium studies. Again, low threshold to involve our gastroenterologist and surgical colleagues. And for antiparasitic therapy, and this is actually coming from our HIV guidelines, but it applies to patients not having HIV too. You use benznidazole for an adult. Typically, you would use a dose of 300 milligrams. There's weight-based recommendations, but doses over 300 milligrams are even more poorly tolerated or not as well tolerated. There's nifurtimox as well, and initiate ART. But as a note, I'll talk about later who, not everyone should be getting antiparasitic therapy because in advanced stages, they're unlikely to benefit from it, and there's a lot of tolerability issues. So some considerations about antiparasitic therapy and antiretroviral therapy. The INSTI class is preferred over PIs or NNRTIs due to potential drug-drug interactions. IRIS is rare, so there's no recommendation to delay the ART start. The role of secondary prophylaxis is unclear. You know, someone presents with AIDS and CNS Chagas, but in South America, there's like 3 times weekly benznidazole has been used. And so here's kind of a summary of who should be offered treatment based on who should benefit from it the most. Infants with congenital infection, acute phase reactivation, children, adolescents, organ donors, laboratory accidents, women of childbearing age, when they're not pregnant or breastfeeding. The benefit is clear. And it kind of makes sense, you know, with this chronic infection that it's had less time to cause, you know, the residual damage to the end organs. So the idea is that you clear the infection before it really causes serious end organ damage. Areas where, you quote, probably treat because the evidence, you know, there's not as clear-cut benefit, but definitely possible or probable benefit is the main one I wanted to talk about is in the middle, the chronic indeterminate phase. So an adult that was, you know, identified through screening, they're age 19 to 50 years old, and they don't have advanced cardiomyopathy. So patients with, you know, advanced cardiomyopathy, there's the benefit to treating with, you know, I'll show you the study. A very extensive, well-designed study showed that there's no benefit to treating. It's probably that the residual damage from the inflammation is more what's causing the disease process than the actual parasite at that point. So the recommendation is not to treat. But of course, there's a lot of, it's important to keep in mind that they have Chagas because that, you know, of the particular potential for arrhythmias and possibly planning for heart transplant. And if they have early digestive involvement or early cardiac involvement, you can also consider treatment. And pregnant women definitely don't treat, but you know, treat once you can in between pregnancies. And so this is the trial, the benefit trial. It published in 2015. It included 2,800 patients with Chagas cardiomyopathy, which is quite the undertaking. They compared benznidazole versus placebo and followed them for 5 years. And they found that antiparasitic therapy reduced the parasite detection, but did not affect clinical outcomes. So it was assessed that it's not beneficial. And so now I'll go into a study that I had a small role in where we assessed diagnostic practices at 4 major hospitals in California and Texas. So one of the California hospitals was UCSD. It was an observational study. Data was collected between 2016 and 2020. Tests that were conducted between those years. Overall, we found low rates of testing, and most of the time the tests were ordered in older patients with end organ disease, so poor candidates for antiparasitic therapy, low possibility of them benefiting from it. And overall, our conclusion was that there were missed opportunities to identify and treat chronic indeterminate disease. So just to go into a little bit more detail, of the patients that we saw that had gotten serology for had gotten Chagas serology. A lot of the people that were ordering, most of the people ordering it were cardiologists, some infectious diseases specialists, and of course there's a caveat that maybe the infectious diseases specialist was recommending it and someone else ordered it. Some gastroenterologists, hematologists, oncologists, a lot of times in the setting of preparing for, immunosuppressive chemotherapy, internists. And unfortunately, well, and our, one definite finding of interest was that it was rarely ordered by gynecologists. So, and I know in particular one of those times it was ordered, the patient came in saying, I've been diagnosed with Chagas. So it wasn't screening, it was, kind of confirming a reported diagnosis. And then for looking further at who tested positive, you would think, oh, maybe, it's these, mostly from Latin America or from South America, obviously Latin America, but your assumption would, you classically associate Chagas with South America, but actually of those that came back positive, we saw a lot from Central America and Mexico, further confirming that, Chagas does affect these regions. There were, some rare cases of, them being born in the United States, it was rarely positive in people that were born elsewhere. So who, these are looking at who tested positive, what disease they had. And, obviously heart failure was a big one, or other cardiac findings. And then we also looked at dysphagia and abdominal pain, which was pretty rare for the positives. And so a lot of what I've been talking about has been, Chagas in the, general population, not specifically those living with HIV, but just something to consider is that, several South American countries recommend screening at diagnosis or entry to care with serologic testing. And, but the implementation of that is impeded by limitation of resources. US and Spanish guidelines recommend people living with HIV who have epidemiologic risk factors. They do recommend screening with serology, but screening again remains limited, even though these are higher resource settings. And the relative cost of a Chagas serology is negligible compared to all the other tests and diagnostics we order. And so these are from our HIV guidelines. And just wanted to show you the quote in case you haven't seen this page of it. All people with HIV who have epidemiologic risk factors for Chagas disease should be tested for antibody to trypanosoma cruzi. And epidemiologic risk factors is defined as at least 6 months residence in Mexico, Central America, or South America, kind of skipping the Caribbean islands. And in those that, and again, the same language of, when to use antiparasitic therapy. Now, a little bit more about Chagas serology. A single serologic test is not sufficient to make a diagnosis. So you should use 2 or more tests using distinct antigens or techniques in order to confirm a diagnosis. And these techniques include ELISA or IFA. And like other serologies or testing in the setting of advanced AIDS with immunocompromised, there's a risk of a false negative. So they're in the process of trying to figure out better diagnostics that we can use. And so this is a study at UCSF where they assessed blood donor samples and to really see which of the, we have various assays available, and so to see which ones might be the best. There's various Wiener assays, Hemogen, Ortho, and just to take a step back. So Wiener is Wiener is the assay that's available at Quest. And I apologize, I wasn't able to find this out for the purposes of the talk. It's either 3.0 or 4.0, I believe, at Quest. Hemogen is the assay that we get when we order it through UCSD labs. It's a send out to Arup. We don't do this in-house. The ortho assay is a lot of times used for blood donor screening. And outside of these are the assays, available at commercial labs, and outside of that, the assays are, I believe, just run at the CDC or on research basis. And so if you look at the hemogen assay, its sensitivity is actually lower than the Wiener assays, suggesting that we might be missing some diagnoses. But fortunately, the assays all have pretty good specificity. And then, sorry for the layout of this, but if you're breaking it down by where the patient may have been exposed, South America, Central America, Mexico, unfortunately, the sensitivity and so the sensitivity, unfortunately, suffers because which makes sense because these assays in general are developed in South America. So if you're seeing, because the parasite, there's obviously differences, across geographically. So unfortunately, our patients that we see here that are more, the patients we're more likely to see and diagnose with a true Chagas disease, the sensitivity is poorer, especially for the assay that we use as a default here at UCSD, although the sensitivity is pretty good. I guess not horrible in that it's 88, but quite different, or 82, but quite different from the Wiener 4.0, the latest generation, 98 to 100. So sorry, I rushed through that, but I thought there might be some discussion at the end. So in summary, Chagas disease is estimated to affect 300,000 residents in the United States, most of which don't know that they're infected, whether it be access to care or index of suspicion of their treating provider, or knowledge of Chagas of the treating provider, because a lot of us learn about it in medical school or training and then don't really think about it much afterwards. 20 to 30% of those chronically infected will develop end organ disease, which can be quite debilitating. US and South America guidelines recommend screening in patients living with HIV, but in general, we're even at major academic centers, we're not screening very often, and when we do test, it's often after the point at which antiparasitic therapy would be beneficial. Many barriers exist to implementation of screening, leading to missed opportunities to diagnose earlier and potentially curable stages of disease. And then I just wanted to make a plug. A lot of the slides I actually took from this because I thought it was very helpful and good graphics. There's a little, if you want to do a deep dive or kind of go through it again after my presentation, there's a little learning module through the CDC. I provided the website there, pretty user-friendly to kind of go through the basics of Chagas disease. So if anyone that wants to feel more comfortable testing for it, counseling patients, and potentially managing it. And there's a lot of resources at the CDC. If you identify a positive test and you want to coordinate, confirmatory testing, decide, is someone an appropriate candidate for treatment, et cetera. Okay, and any questions or comments or suggestions?
JD Malone, infectious diseases. I just thought I would ask a little more about, a lot of those initial screening things, very sensitive, and so we get a positive hit for that.
Yeah.
But that really, as you said, you need 2 tests
Mhm.
to do that. can you go into a little more detail about what test you run the first, what test you run the second, from a public health standpoint? Yes, if people are reporting positive tests, we expect our numbers to go up, but that I'm not sure those are really diagnoses. And can I also ask the question about this is congenitally transmitted, and that pregnant women, screening pregnant women would probably be very beneficial for the high risk group. I understand that you're not going to treat a pregnant woman with benidazole, but that can you go into a little more detail about that, what you're thinking about? Over.
Sure, yeah. And so I probably should have gone into a little bit more about the deals of confirmatory testing. Overall, the message is in order to make a diagnosis, you do need confirmatory testing. Our colleagues up at UCSF are working on making it more logistically simple, but honestly, it requires so I believe the county and the state, and you can correct me if I'm wrong, but I believe the county and the state don't help coordinate the confirmatory testing, or I don't directly perform the confirmatory testing, I should say. So it has to be routed to the CDC. Some states, they are able to perform it right at their public health lab to assist with that. Some providers use, if they screen positive with the wiener, then they also do the hemogen, but realistically, I think it's best to coordinate with the CDC because try to coordinate with the CDC, but that's also an option. But at UCSD, that would require saying, oh, you got your first lab at Quest, now you have to do your second lab through Arup, at UCSD. It's not like you can specify using different assays. And I believe Quest has some language that they would coordinate the confirmatory testing, but I would help coordinate it, but I would definitely be in contact with the lab to make sure that they're helping it with that. But yeah, it can be logistically difficult. So having a little threshold to reach out to the CDC where the Chagas experts are.
Dr. Beatty, my public health colleague, has his hand up and will certainly save me. Over.
Oh, okay. Sorry. Yeah, feel free to correct me because things change over time too. Oh, okay, correct. Okay, good. Thank you.
Go ahead, Dr.
Yeah,
Beatty.
Jeff Whitman at UCSF is trying to make it better. He was the main, or one of the main authors on that paper with the slides I show you comparing the different assays. So maybe that, I think maybe he's trying to have his lab be the reference lab for California. I don't know. So maybe this will improve soon. But yeah, lots of people are aware it's hard to confirm it.
Can I ask a question, Jill?
No, there are a couple of other people before you. Sorry. Dr. Beatty, do you want to, or is it Mark Beatty? I'll get to you, Nettie, sure. I promise.
Sure. One question is a question and a comment. So you mentioned damage to nervous tissue. I'm curious, does the parasite have tropism specifically for smooth muscle? And that's typically why it's cardiac and GI, and that tropism leads to scarring, which causes the functional problems of damage to nerve tissue, interruption of cardiac electric signals that cause the arrhythmias, things like that.
Yes, it appears so. And there's but I think there's also studies ongoing to kind of tease apart reservoirs, just like with HIV infection, to better understand that. So but yeah, it definitely seems to have a tropism for smooth muscle.
Okay.
And
the other comment, it seems like the screening of pregnant women has like a double impact, because both now that we have treatment available for children, in the newborn period, both the mother can be identified as with her infection, and then the child can be also identified for treatment. So it seems like that would be the way to go. What is the thinking around that particular? I know you're focused on HIV, which is
sure.
a different group per se, but I'd be
Yeah.
interested to hear your thoughts about that as well.
And sorry, I skipped over John Malone's question on that. So, there's a lot of people for, one, summary is that it would be, this is a great time to screen because you're catching someone that's, inherently younger. And it really would change the neonatal management and monitoring, aggressive testing and, treatment options at a point where it could make a really big impact in that neonate's life. And then obviously testing the mother, maybe that's not her last pregnancy. So, preventing another transmission and also decreasing the risk of, end organ damage in the mother. So this is, sometimes, these are people where, their prenatal care might be their main contact with medicine. So kind of capturing them at that point with, doing a blood draw that they would normally do to test for all the other things that happen in prenatal care. But it is, I think as Dr. Aldous has pointed out, that is a lot for a woman to take in at her prenatal appointment. There's a lot of other things going on. Just saying, oh, so I guess it would require a lot of, knowledge on the provider, oh, this is part of the panel because, you've lived in, Latin America for 6 months, or maybe, a suggestive family history, a mother that, passed away of sudden cardiac death or something to where they may have been exposed, congenitally, and just saying, we're testing for this so that we know how best to treat your baby. Yeah.
Yeah, I mean, incorporation of that into the prenatal panel really makes sense because we don't have a lot of touch points to get this kind of information, and the benefit of impacting 2 lives really can be super important. So it's a great opportunity. Sorry, last question.
Yeah.
Is there a specific, what are your thoughts about why Chagas and HIV would show up in the same person? Is there particular risk factors, or just that the distribution happens to be that you would have these two types of risk factors fall on the same people?
Oh, sure. So I'm sorry I didn't include this, but there was a study that showed that, Chagas the prevalence is similar in seronegative and those without HIV, but, it showed up specifically in the HIV guidelines, but overall the consensus is if someone has epidemiologic risk factors and they don't have HIV, they should also be screened. But it's particularly in the HIV guidelines to kind of, as part of the summary of screenings, appropriate screenings. But obviously, in a patient with advanced AIDS, it has, certain rare but unique presentations as well.
Paul, I'm going to come back to you in a second. I think Sarah and Nettie have similar questions, but Nettie, you can jump in if I get this wrong. I'm also curious. Sarah wrote, I'd love to hear you walk through how you would assess a Mexican patient or a patient from Mexico. I just asked, like, a brand new patient comes into a clinic with HIV. What, is the recommendation that you take a travel history or, some kind of history and then decide if you're going to screen? Can you talk how you would do that and with which patient populations? Within HIV, I'm saying specifically.
Sure. Yeah. So, I mean, the primary care I do is for, so, I mean, when I'm, I've seen this type of patient at San Isidro or UCSD too. I just ask, where are they from? Did they live in that country for 6 months? And then that tells you if they should be, screened for it, and just say, oh, this is an infection that you can be exposed to. And, if you, with that history, so I'm just going to order that test. And I haven't had people say, no, thank you. So and you can just, and
you
then
order that pretty regularly, I'm guessing, in patients, maybe at San Isidro. I don't know. I'm just curious the volume
yeah.
at which you're doing this or how often.
No, I mean, and I'm a fairly young attending, but, so, since I'm managing it myself now, I just go ahead and screen myself, and I have it part of my little dot for ACE at the end. you know, so my colleague at Baylor, Dr. Ava Clark, she is an infectious diseases specialist. Oh, Paula Granato, so hi. Yeah, and like I said, and everyone can chime in and correct me if necessary. But she said, you know, she has it in her panel, you know, they get it at intake, you know.
I think
Just
that's
trying
what
to
I'm
make sure
getting at.
everybody
Is
gets
it's
it at
something
intake.
that should be at
You know, like
intake
we're
if
texting,
they,
you know, we're going to check for toxo, we're going to check for Chagas, you know.
right.
And she's not sure, you know, if everyone's getting that, you know, making sure that they have an epidemiologic risk factor, but there's autochthonous, you know, local transmission in Mexico, and, you know, the possibility of them having a mother that grew up in Latin America or having lived in Latin America is so high that she's okay with maybe it not, you know, them not really, you know, double checking. But, you know, it's like two questions to see if they have epidemiologic risk factors. You don't have to be asking, you know, what type of place did you live in, you know, like if you don't want to, you know. But yeah.
Hot off the presses, at least at UCSD, we're going to add it to our intake labs. Paula, do you want to, I know you've had your hand up for a while.
Yeah, and Kathy, this was fantastic. You know, I'm such a fan of all the work that you're doing here in San Diego, and I was just going to add a couple of quick things. One of the things that going back to the pregnant moms, like it's not just like the double thing, but we're also finding that oftentimes whenever you find the pregnant mom, that you'll test, we do the domino testing where you test the other family members. And we're finding you'll find 1 to 5 more family members in the household that are also positive, not just the children, but the tias or the tios and the cousins who all are similarly living in the you know, the same sort of not just household but the extended family. And so in Texas, I know we were finding multiple cases in the same house once we found the pregnant mom, and so that's why we're definitely thinking about how do we implement screening programs starting at the pregnant moms for all the reasons that you listed. They're already there and they're seeking care. And I was just talking with Dr. Kyle Robinson yesterday. I think he's a resident working at the family health centers, and he wants to put together a presentation for the OBGYNs. And I think Dr. Janine Young also at UCSD was sort of initiating this. So we're going to try to put together a CME or at least a quick talk for the OBs, GYNs locally for the FQHCs to see if we can start, we can add it to that prenatal screening panel. And I think he's going to be really great at also like helping to start implementing this at some of the clinics. And lots of clinics in Texas and other places are starting to do it, and they're finding cases even in the non-targeted. But what was interesting is we've been finding cases in like Haitian populations, the people that are passing through, like coming through South America and coming up through the US. So that kind of surprised me. I was like, wow, I never thought about, you know.
Oh yeah, that's a good point. Like a lot of Haiti immigrants like spend a
Mhm.
lot of time in, you know, conditions where they could be exposed to Chagas. So really asking, you know, I know you're from Haiti, but how did you get here?
Exactly. And I just went to a conference in Texas, the Diseases in Nature conference, and there was a great presentation about a case of a woman who had migrated from China through South America, and she tested positive. So I thought that was really interesting. And then I guess my last comment was that I also speaking with my colleagues in Texas this last week, they were saying that they're having some concerns about the ARAP testing. And they've got a prenatal clinic there that's screening pregnant moms, and they're having a really high rate of false positives with the ARAP. And so taking that into consideration, you know, we're big fans of the Wiener as being the best we can do. But something to think about. Sometimes you can't control where the lab tests get run, but just taking note that they're doing this blanketed screening there, and the rates of false positives with the ARAP testing is concerning for them. So and then just to add
Just to
on
point out at UCSD, our default is Arab. So
yeah. And so, you know, just taking that with that grain of salt. So it's like, you know, that's why that secondary testing is important. But I know some people come in with the blood donor testing as a positive. And then if you get a positive or an inconclusive or even a negative with any of the other tests, that's you still confirm it with the CDC. And with the CDC too, they always want people to go through the local health departments. And so that's what Mark was saying is like they can help get that confirmatory testing done through the CDC.
Sorry, Nettie's had her hand up for a while. JD, are you responding to what
No,
was said?
I always like to listen to Dr. Aldhouse.
Okay. Dr. Aldous, it's for you.
Hey, how nice to see you, JD. Kathy, thank you so much. So I've been working with Kathy for a few years now, so I've heard her Chagas talk, and I really appreciate it because it's reminding me of something that I'm missing. But I'm also struggling with how to balance risk and benefit and not causing harm with the screening. So it's a little bit like the anal cancer, where it's like, we know that if someone has it, it's great that we detect it and can prevent disease, but that's not the same as knowing how to look for it without causing a lot of harm while we're looking for it. So, and I mean, a lot of harm sounds dramatic, but I worry about the sensitivity of these tests, how difficult it is to really diagnose. And so you've got a positive, but then you have to wait for another positive, and you're not confident in the testing. And so then you're causing a lot of patient anxiety while you're waiting to sort of find out what's really going on. So that's my main concern. I'm curious if others are. Because I work with Kathy, I want to roll out Chagas screening, but I'm also very thoughtful about what it might create as far as a lot of noise in the clinic and what to do with the results, and really making sure we have the infrastructure. Same with the OB screening. Do we have the infrastructure to really properly counsel, to know that we're diagnosing people properly and getting the right follow-up? So I'm actually interested in a community conversation if anyone else is struggling with that, wanting to move forward, but not knowing how.
And I had real
chime in.
that,
Sorry.
that
You can go.
there's a degree of, to me, there's a degree of social stigma with this disease that's associated with campesinos, relatively, poor peasant farmers for a lot of individuals. And I think there may be some concerns underlying that persist with this. Over.
I would feel much better screening if I felt more confident in the test results. I mean, I know it's a recommendation, so I get that some people are saying the risk and benefit is there for screening, obviously, or it wouldn't be a recommendation. But having seen the early days of other types of, cancer screening or whatever, we can cause a lot of trouble if we don't have good tests and methods and guidelines for the screening. Once you find someone, it's like, great, I'm so glad I found them and prevented this disease, but we have to also think about all of the other errors that may have gone into diagnosing that one person.
I will say one thing I do, or one thing I make sure I explain with counseling is, I mean, in the US, that it's most likely that we're diagnosing them in the chronic form. So that, we can wait, it's hard to wait, but, the difference between starting therapy today and a few weeks or months from now is pretty negligible. So, although it's frustrating to wait, and hopefully that'll change, with Dr. Whitman's lab at UCSF, we fortunately have the luxury, it's okay to wait because to determine the appropriate treatment course, and if they actually need treatment, if they would benefit, from it.
Dr. Gurlati's been patiently waiting. He put a comment in earlier.
I'd love to know what your question is from a psychiatrist. Yeah.
Yeah. Yes. And Dr. Blumenthal, don't worry, I'm used to being ignored in this forum. And yes, I'm sick. And I don't usually actually unmute, but this one, so you have to correct my understanding here. You showed us the sensitivity and specificities of these tests, and they were close to 100%. So why do you need two tests, or was that results if you did two tests that you got those sensitivities and specificities? And then my other question, which I had put in the comments, was about specifically not treating somebody with advanced cardiomyopathy. And you had mentioned that some of them actually then will go on to transplant. And I was thinking, well, why wouldn't you treat somebody who might then have a transplant? Because that is an indication to treat. And then, was this study, I didn't obviously read it, but was the study really looking at all outcomes, or was it just looking at cardiomyopathy outcomes? And is there any benefit of treating somebody who's got chronic infection just in general, and maybe doesn't have an impact on the outcomes in cardiomyopathy, but if you've already had cardiomyopathy, but does this is there any other benefit maybe to treatment in those cases?
Okay. And correct me if I missed one of your questions, but so for the treating the patients that then maybe go on to develop cardiomyopathy, the reason why they would end up then maybe getting antiparasitic therapy later is because in the setting of immunosuppression, reactivating. So if you're transplanting someone with Chagas cardiomyopathy, their overall transplant prognosis is pretty good because in general they're younger and they didn't develop their heart disease from poorly controlled diabetes or other causes. So fortunately they are good transplant candidates, but one of the post-transplant monitoring part of the protocol is to aggressively look for reactivation of Chagas, even laboratory reactivation, to protect that new heart. And so if they do find evidence of reactivation, it's kind of like the acute, this is a new, reactivated, a new acute infection, that's when the benefit is higher and you're protecting that new heart rather than trying to reverse the scarring in the old heart. And I should have probably included a list about, how poorly tolerated benznidazole is. You can have a lot of nausea, vomiting, skin changes, nervous system symptoms. And I believe, I had one patient where I was like, is this even worth it? And it was a laboratory reactivation after heart transplant. And, but we fortunately got him through it, but it's very hard to tolerate. And then in someone, with advanced cardiomyopathy, they may have they obviously have a lot of other stuff going on. So that's why, they did this detailed study. It was led by a cardiologist, and they looked at a lot, at a lot of cardiac and outcomes and deaths, and they really couldn't pick apart a benefit from it. And the idea is that, again, that it's the residual scarring rather than ongoing damage from the, the parasite actively damaging. And I forget what the other questions you asked. I'm sorry.
It was why.
Oh, the sensitivity and specificity.
Yeah, and why 2 tests versus just 1?
So those specificities looked pretty good, but in real, so this is in blood donor specimens. So in real life experience, like Paula Granados was saying, we do see a fair amount of false positives. And so since there's a lot of implications about, this patient carrying a diagnosis of Chagas disease for the rest of their lives and having all their family tested and then maybe having to go through this poorly tolerated treatment, it's really important to to investigate if it's a true positive with the 2 serologic tests. And that's the CDC recommendations. Maybe we'll have better serology at one point where you won't need confirmatory testing, or maybe it'll just be nice to do it nice and simple through a lab. You don't have to put in a new order, but at this time, this is the recommended algorithm by the experts.
If I could just chime in, I think the reason for the diagnostics being so poor has a lot to do with the genotype of the parasite. And it's unfortunate that the genotypes that we see mostly from Central America up through the US is the genotypes 1 and 4. And so far, the Wiener recombinant test only seems to be the one that's picking up those more, regularly. And the other genotypes that we see more commonly in South America was where most of those tests were developed. And so the diagnostics just aren't there yet, but we're hoping that soon. But the Wiener test seems to be doing really well. And the ortho ELISA test that the blood donor screenings are using are so sensitive that they're just picking up, a lot of cross-reactivity and lots of false positives. And so hence, the double testing and with the confirmatory, we've got a couple of people who are in Florida and a couple other places who've also been using the rapid testing, the lateral flow tests, which are also we're questioning a lot about their sensitivity and specificity for the genotypes 1 and 4, but it's also a new tool that InBios puts out that we're working on seeing how good they might be for especially these prenatal screening clinics where you can just do a rapid test and then order out the commercial test afterwards and then confirm. So lots of work going on with the testing. It's just a bit complicated.
Yeah, and like with any screening testing, you want to start with something sensitive and then follow up with something more specific. So that's the hope that we'll have a little bit more clean algorithm, but the algorithm of testing is based on what the resources we currently have. So.
And I was just going to say really quickly too, sorry, with Nettie, with your thing about the looking at the online results, absolutely, but also the blood donor screening letters. They get this letter from the Red Cross that says you've tested positive for Chagas disease, you're no longer eligible to donate blood. Go talk to your doctor. And then often the patients will go to their PC and the PC is like, don't worry, it's a false positive, or we don't have Chagas in the US, or so we're trying to, you know, turn that into a little bit better education on that too, because that's a pretty freaky diagnosis to get in a letter from the Red Cross.
Okay, sorry everyone, it's 9:03. I'm gonna have to cut this off so people can get to work and do other things. Kathy, obviously this was an incredible talk, so much discussion. I think we all learned quite a bit, and it's wonderful having our county colleagues and others join us, and please come back for other talks. But thank you so much, and I believe we'll see everyone next week, although we just learned our speaker canceled. So we may get a free week unless we can scramble and find someone. Anyway, Kathy, thank you so much. Really appreciate it.
Bye.
Bye, everyone. Have a great weekend.